Welcome to the webinar today. My name is Saumu Lwembe. I work for the National Institute for Health and Care Research as Assistant Director for Community Engagement and Involvement and Patient and Public Involvement and Engagement. I am delighted to be chairing this webinar today, jointly with my colleague Gary, whom I will hand you over so that he can introduce himself. Gary, please.
Lovely. Thank you, Samu. And hello, everyone, wherever you are. My name is Gary Hickey, and I'm a Senior Research Manager at the National Institute for Health and Care Research in both patient and public involvement teams and indeed in research inclusion. And I'll be hosting the questions today.
Thank you so much, Gary. Today, we are also delighted to be joined by the NIHR Director for Research Inclusion, Dr. Esther Mukuka, who will have an opportunity later on to introduce herself and share reflections of today's webinar. Now, this webinar today is the second in the series of webinars in a program of work which will enable reciprocal sharing of global health innovations in working with people and communities. And this could be novel ideas, inventions, processes, approaches, and learnings aimed to improve health and social care research outcomes. We have the privilege today of hearing directly from those directly involved in NIHR-funded projects, both in the UK and lower and middle-income countries, who will help us today to explore to what extent public involvement in health and care research differs or is indeed similar across different geographical settings or disciplines. It is with great pleasure to introduce the four panelists. Well, three. There's one who is running late, but hopefully they will be able to join us as we go along. And these panelists are acknowledged experts that bring in their lived experience in the NIHR research. We believe their stories of involvement will both inspire and challenge our approach to working with people and communities. So the first panelist I want to introduce to you is Charles Butcher. Charles is a retired international corporate treasurer and finance director with the focus on early ventures in medical diagnostics, bringing invaluable experience both as a patient and carer, working closely with NHS groups, research pharmacists, and pharmacy educators to improve patient and public involvement in healthcare. Our second panelist is Milka Mwamadi. Milka is a community involvement lead for the past 5 years in a stillbirth neonatal death in the NIHR Global Health Research Project, where she leads on 8 project work streams in Malawi, Zambia, Zimbabwe, Tanzania, Kenya, Uganda, Pakistan, and India. Milka also trains colleagues as the unit lead, where she trains them on community engagement and involvement and how they can form and run community engagement and involvement groups. Our third panelist is Hilaria Asumu. Hilaria is both a politician and a healthcare advocate with a focus on organ donation and kidney disease. Hilaria's advocacy work is driven by her personal experience of kidney disease and a life-saving transplant. In addition to her role as a councillor for Walkeden South, she is an advocate for health inequalities with a strong focus on women and the Black community, as well as healthcare and community reform. And she has founded the UK's first Black kidney charity. Given that our fourth panelist hasn't joined us yet, I will hand you now over to my colleague Gary to continue with the conversation.
Fantastic. Thank you, Samuel. And welcome, Hilaria. Welcome, Charles. Welcome, Milka. Lovely to see you all. The first thing I want to do is explore your motivations for being involved in research. And I'm going to turn over to Hilaria first. Can you tell us what was your motivations for getting involved in research?
Well, I think my personal experience being a kidney patient. So I'll just tell you a little bit about that. So in 2008, I had the miscarriage at 22 weeks, and that deteriorated to septicemia, multiple organ failure, 2 cardiac arrest, and I was in a coma for 2 weeks. And when I came out of that coma, I was told that the multiple organ failure had affected my kidneys, so I had to go on dialysis. So I was on dialysis for a little bit, and then in 2010, just before that, they took me off because my kidneys improved. Unfortunately, in 2010, unfortunately, I got pregnant again, and same thing happened. At 22 weeks, I had a miscarriage, septicemia, multiple organ failure, 2 cardiac arrests, and again in a coma. And when they were bringing me out of this second of the coma, my lungs collapsed. They had to reintubate me to save my life. And I was in the coma for a while, trying to wake me up. I wouldn't wake up, and the doctors gave my husband a date when they were going to turn the machine off. And fortunately, the morning of that day, I woke up. So in the course of my, in the course of my, I had to go on dialysis, obviously, because, the multiple organ failure has affected my kidneys again. But, whilst I was, doing that, I was told I had 10 years plus wait before I could get a kidney. And I did wait that 10 years plus, and I got my transplant in 2018. And when I did get that transplant, I actually got in touch NHS Blood and Transplant, which is the main body that campaigns around organ donation in the UK, got in touch with me and asked me if I would like to join them. So I did. And whilst, I was campaigning, I realized there were a whole lot of issues within the Black community in the UK. And obviously, we all migrate around the world, especially to the Western world. And people leave their homes with their beliefs and their cultural practices and all of that. And, coming to the UK, it doesn't change their beliefs all of a sudden. And I noticed that my community would not even engage on that level. And there were a lot of issues that those people in power, those people who were doing the research, didn't have those ready information to use to help us as a community. So I started working not just with NHS Blood and Transplant, but also with Kidney Research UK and also Research for the Future, trying to get people on board to see, how they could help to, increase that knowledge around how different diseases affect us. Because when you look at the number of people who are being treated, the system is not created around us as a Black community. It's around the white community. So that's how I got involved in research.
So very much like an altruistic motive and to change.
Yes.
And it was driven by previous negative experiences to kind of make things better.
Exactly.
Yeah. Fantastic. Thank you for sharing that, Hilaria, as well. Thank you. Milka, were your motivations sort of similar, sort of generated from similar circumstances, or that idea of trying to change things, or was it something different?
Yeah, so I can say that my experience is more similar to Hilaria because I had first-hand experience in the research that was taking place at the moment when I got recruited. So I had my first pregnancy was actually a miscarriage, and then went on to have a successful pregnancy. After that, we had a death. We were expecting twins. Unfortunately, they died in the neonatal care. So when I heard about this research, I said, oh, well, I may not be a health professional. I'm not a doctor, I'm not a nurse, but I really want to help the health system in how we can help the community to have better facilities in our communities so that something like this, the same pain that I've had, can be avoided. So that was my motivation. I didn't want a family or a mother or a father or anyone else to go through the same pain that I went through.
Brilliant. Thank you, Milky. So again, it's that similar kind of challenge, isn't it? About an altruistic feeling. I want to improve the services given previous experience that you've had. It's really, really powerful. Charles, what about you?
Thank you. Mine's slightly different, I guess, because my working background was accountancy and raising funding for early stage ventures, including medical diagnostics, and working with researchers, medical researchers, doctors, scientists, and I found that very rewarding indeed. But the way I got into this was pure luck, really. I was carer for my elderly mum, who was getting on and into her 90s, and I'd take her into one of the London hospitals, and she wasn't doing all that well, but they said, no, you could leave, I could come and collect her. So I took her out of the hospital again, and I was asked for the medication, and the medications I was given were anticoagulants, warfarin, for my little old mum, small of stature. I said, what dose? And I was told the dose, and I was taking warfarin myself then, I moved on to something else, but I said, that doesn't sound right. And I was told, no, that's the dose you have to give. You know, it's 9. And I said, no, that's not quite right. So I said, I want to see a doctor. And doctor came and said, oh, no, goodness me, you've been given the wrong dose. It should be this dose. So I went back. And the luck was that I was part of a walking group, and I was still upset the next day. And I was talking to my colleagues as I was walking, and this lady, she started laughing her head off at me. And I said, well, this is not funny. It was very serious. She said, Charles, have I got a job for you? And she was a research pharmacist who'd listened to my story as we were walking around. And she said, come and join us, please, with your examples of being a carer, medical research and connecting with the NIHR would be just the right thing, we think. We'd like you to come join. So that's why I joined, and that's 12 years ago, and I'm still at it.
So circumstances very much for you, Charles, is that right? So you kind of fell into?
Yes, yeah.
Okay. I'd like to explore now some of the challenges that maybe you've all experienced being involved. And as Charles is in the spotlight at the moment, I'll continue with you, Charles. What sort of challenges have you faced in your experience of being involved in research, both as a patient and a carer?
Well, the challenge is, I think, coming into this, as I explained, brand new, it was all very new to me. I'd been involved working within the NHS as a layperson, but I thought it was very, very, very new indeed. And I think I was very much helped by the person, the researcher who brought me into this, and also the other people on the studies that I was drawn into. They gave considerable support to me, but it took some time for us to get hold of these things and to understand what we were expected to do. And the challenges really were to understand not being just a token member of the public, a patient and public member, but how could we contribute? And I think it was how it would evolve 12 years ago that we were able to move this along. And also we found that we could actually participate more than just sitting in on the research meetings. And that we might want to develop a little bit later, Gary.
Well, let's go through it a little bit now, Charles. So what kind of what support structures or what did researchers do to enable you to be involved? Was it training? Was it mentorship? Was it any of those things?
Yes, there was training, training really about the research project we were involved in, and then also we were invited, well, we actually put ourselves forward to contribute to it a little bit more. And so what we said, well, can we help collect the data? And the researcher said, well, and the professor said, I don't see why not. You have to be trained for that. And so, in fact, what happened was that we were vetted, of course, because we were working on a project, a research study relating to inpatient medications and how the new systems which were coming on board were working. And so we actually then were taught and were allowed to go and collect data. And furthermore, following on from that, we were taught how to analyze the data ourselves. So we were working amongst the researchers.
Brilliant. So in effect, you received some kind of training, and that enabled you to be, rather than just sort of landing you in it and then saying, get on with it, Charles, you actually received some training to help you to be involved. Brilliant.
Yeah, yes, indeed. And that made us, and I should say, that made it very much more worthwhile in the research projects that we were getting involved in, because we thought that we were contributing a little bit more than just sitting around a table once every 3 months or so, listening to how the study had been going.
So meaningful involvement rather than tokenism.
Yes.
Thanks, Charles. I'm going to move on to Hilaria. Hilaria, can you tell us what some of the challenges you've faced and what structures or support was put in place to enable you to be involved effectively?
I think the first thing that was done when I joined was to train me. It wasn't just me and other people from the Asian community as well. And we had a lot of training. I do a lot of research. I get involved in a lot of research. So I get a lot of training, different types of training, depending on the type of research that I'm involved in. And just recently, I became a fellow of the Federal Health for All Fellowship. And one of the training they gave us, they actually got people who do a lot of research, and they talked us through the methods, what they do, how they do it, and we had that opportunity to ask questions. And then we had field work. So we're asked to go to hospitals and, get a lot of people involved. So we go into the renal units to talk to people and ask them questions. We get consent first. And believe me, it was really difficult at first. My first one was difficult because the patient didn't want to talk, and I had to move to the next person. By the time I was coming back, I just said, "Oh, hello, I'm leaving now." And they said, "Oh, come over. What is it were you talking about?" And, I sort of like broke down the ice, spoke about myself, because they always tell you your story should be the first thing you lead up with after the pleasantries, because sometimes patients or those people you're trying to get on board would be able to sort of like, they'll be able to sort of put themselves in your shoes and, understand where you're coming from. Then you can lead that conversation. So there were trainings, there were trips, there were, talking to doctors, nurses, you name it. So I think for me, because I'm actually quite interested in research, especially for my community, sure, I didn't think it was a challenge for me. It was actually very interesting, because when you have that passion that you're looking for a solution, being on dialysis for 10 years is hard. And that is 4 times a week dialysis, 3.5 hours each time. By the time you get home, you're exhausted. You really don't want other people to go through that. So when you get an opportunity to make a difference, you look at it like it's my way of giving back. Because my donor family, they lost their child, and they still had that presence of mind to say, I want to donate to help 6 other people. And I'm here today talking to people who are listening right now, about 152 people, about my story. Without that mother agreeing to organ donation, we wouldn't have done that. And, at that time, they told me 10 years plus. Just recently, I went to the hospital with a kidney patient. And do you know that the doctor told her that research, patients now don't have to wait that long. 3 years. It's come down from 10 years plus to 3 years. That's progress. That's research. And we need more people getting involved in research to bring it right down in line with our white counterparts. So when you talk about challenges, I don't see challenges. I see opportunities.
So your motivation in there is, it seems to me anyway, is very much kind of been your strength, if you like, overcoming perhaps any maybe uncomfortableness that people maybe feel about being involved in research, and that's really shines through. Thank you. Yeah. Milka, what about you? Challenges that you've faced, and what you think has been put in place to help you overcome, or not just you, the research projects overcome those challenges?
Yeah, of course. If I say that there were no challenges, then it would be more angelic. But we've had challenges, especially working in the health sector, whereby as I've already said, that I'm not a doctor, I'm not a nurse, but then I've had to work with most of our stakeholders, nurses, they are doctors. And then there's the research assistants, and then there's the whole research on its own. I'm just coming in from a field whereby I'm just an event planner, and then I have to start talking about SBD. What is SBD? That's stillbirth and neonatal death. So all this, we had to learn about these technical jargons working in the research. But then we've had like the best mentors, whereby we were trained by the research assistants to know more about what was the research all about. So when they taught us about what the research is about, then we were thrown into the neonatal fields, and then into the into the health facilities itself to work with the doctors and the nurses. And we've had supportive, we've had the really, really best supportive team, whereby the prime investigator, my prime investigator, was really good. I mean, you'd think that she's throwing you into the pool, but she's throwing you in there because she knows that you can swim, literally. You're capable of swimming. You're just scared, but once you get into the water, you're the fish in the water. So Tina Levin has just been a great prime investigator. And then I had my colleagues that I was working with. They gave me all the necessary resources, all the necessary tools that your first time coming in. So this is how you go about it. And then we've got trainings. We usually have these trainings from NIHR. Recently, we've got this introduction and practice guide for community engagement and involvement, whereby each and every PPI or CEI out there, you have to get that training. You have to know what you're doing in the field. And then we get involved in all sorts of webinars that they are thrown by given to us by NIHR, where we learn a lot about how our other PPIs are doing. And then having the privilege of working in different work streams across 8 countries. I'm talking about from Tanzania all the way to India. I've learned a couple of things or two. So, well, and then we've got the learning and sharing events that we usually do in our research. Even the stakeholders are there. Everyone is talking and you get to learn a lot. So yeah, some of the challenges have been there, but mostly they've been overshadowed by the support that I've been getting in this research.
Thank you, Milka. And a great plug there for the NIHR training, and I can recommend it to everybody on this call. Yeah. Milka, you mentioned that mentorship, I think, about being mentored. Could you tell us a little bit more about that and how that worked?
All right. So when I first got involved in the SPD project, because I was just coming in, I wasn't the research. I didn't know anything about research. There was Carol Bedwell, who was the co-read. So we were working hand in hand. And when it was first started, she gave me all the necessary materials to enable me to walk the path. So we got trainings by the research team to tell us a little bit more, or just to tell us more about what the research was about, so that we knew what we were getting into the field. Yeah.
Brilliant. Thank you very much. And if we could stay with you, Milka, because you are also a community involvement lead. So can you tell us something about your journey? How did you get to know about NIHR research? And how did you progress from being a community member to a community engagement and involvement lead? You're on mute, Milka.
All right. So I started working as a community involvement, as just a community involvement in my country, Malawi. And as I have said, that the research itself is based in eight countries, where we have 8 work streams. Because of the passion that I had, and the more involvement, like the first-hand involvement in what the research was all about. And I was also recruiting other women that have also gone through the same experiences, the stillbirth experiences. So after going through so many trainings, I can say so many trainings, that's when I was able to be moved from one position to the other position.
Brilliant. Thank you, Milka.
Thank you.
I'm going to go back to Hilaria now. Hilaria, you are a healthcare advocate, and you've touched on this already. But could you say a little bit more about how your work in advocating for health equality has informed your public involvement with the National Institute for Health and Care Research?
Yes, so so when I started, I was just, campaigning, just campaigning and talking to people about organ donation. But as I started working a little bit more within the community and going deeper into reasons why people don't engage or why people don't talk about organ donation or illness in my community, I found that, most of the time it's deep-seated distrust within the community. And I have seen firsthand as a patient the experience I went through in the hospital. It's not always good, but I always look at the good side of my experience and put that out within the community. And the fact was that my experiences actually drove my work with the NHS, NHS Blood and Transplant, as well as the NIHR, ensuring that the research that's being done, not just with the NIHR, there's also the Organ Utilization Group, which is a national group set up by the Secretary for Health and Social Care. I wanted to ensure that our voices were represented within those research, because when you look at the makeup of the voices that they are listening to, it's more people from the from the white community. So I was looking at ways of ensuring that our voices were represented. So I was going out in communities and trying to encourage people to come on board and also add their voices to what is being done, so that if they're looking for solutions, they can find those solutions and sort of like help us to find solutions to those diseases that affect us. So I think mainly I think a lot of people need a sort of a way to get into research. Sometimes they don't even hear about it. And I think mainly I want to amplify those concerns that people have, to ensure that those people who are actually doing those research, or those people in government who are looking for ways to find those solutions, they have those information at hand to make that. Have I answered? I think I'm waffling a bit. Have I answered that question?
You really have, but I've got more questions for you, Hilaria, so we can waffle even more. You mentioned there about distrust, and it's something that has come up for me again and again. What can the research community, including the National Institute for Health and Care Research, do to try to address that distrust?
Good. That's a very good question. And this is one of the questions I'm always talking about. And I always suggest it at every group I go into. Now, a lot of people, as I said earlier on, are coming in, they're moving to the West. They're migrating to the Western countries, and they come in here with their beliefs and their culture and cultural practices and all of that. Now, what they need to be doing is, instead of asking them to come to them, you have to go to them in their own familiar surroundings, in those places where they feel most comfortable. And there's one thing people don't realize, most of these researchers don't realize, is that there are two communities currently. I know about the UK, I don't know about the other Western countries, but there are two communities currently. Those who've lived in the UK longer than 5 years, and those who have just come in and up to 5 years. And believe me, the ones coming in don't trust the ones who are here, who have been here longer. So usually we have to go to them to say, we are here to help you. So we approach the religious leaders, we approach local champions, we approach local influencers, and we also try to see if we can find a community leader who is really respected. And we go to them and say, we want to partner with you. Even for me being a Black person, they don't trust me because I represent authority and I'm talking on their behalf. At a point, I was actually bunched with the people I'm trying to get into the community. So when you're going into the community, don't go in alone. Go in with someone from that community who at least looks like them, because you will see the visible relaxation. They become visibly relaxed when they see somebody who looks like them, who talks like them, who behaves like them, and they feel they would understand what they are going through. So when I go in, this is not my normal voice when I'm talking to my people. It's totally different. So it goes deeper and more coarse, so that they can understand and say, this is one of us. And then they would engage with those people, those researchers. And at the end of the day, that is what the researchers want. They want someone who will lead them into the community, tell the community to trust them, and they start working. And in between that, they have to show them, they have to be open and honest with them what they're doing. If you remember the Contigi trials, and that is still, in people's minds about those trials that were done in Africa and, in America and all of that. So we need to break down those barriers by going to them and saying, this is us, this is what we want to do. Ask any questions. No question is silly. And I think that is what they need to start practicing. And also experiences within the healthcare system, they have to start watching that, because one bad experience goes viral in the community. And by the time it gets back to the original person it happened to, that story has changed. So we need to start changing experiences and also going to people within the community rather than them coming to us.
Thank you, Hilary. And how important is it, you think, for researchers, National Institute for Healthcare Research, to actually develop longer-term relationships with those communities? Because one of my worries always is that researchers, well-intentioned, go into a community because they want something, data, etc.,
yes,
and then just they zoom in and zoom out, as it were. So how important is that relationship development?
Continuous development. It is really, really important, and I cannot stress it enough. If you want something, don't go in immediately. As soon as you start to build that research, as soon as you start to look at doing something, or you identify the topic you want to research, you start to make those connections, and then you start to go, what I've done recently, I'll tell you what I've done. As I said, people don't trust me because of my political background and all the other things. I'm well known, so they look at me as the system. So what I did was to approach a church, one of the popular churches where new immigrants would go to, and I approached the pastor, and I went to speak to them first and said, this is who I am, this is what I'm trying to do, this is the organization I'm coming from. But people who are coming into your community, they don't have access to services, they don't get involved in research. I'm coming to talk to them. And I went to their service the previous Sunday, and the next Sunday I went there. By the time I had gone there 3 times, you could see the visible, they were visibly relaxed and were talking to me. So I was able to bring in officers from the council and other services across board, including health professionals, to come and walk in there. Now, when they see me, everybody is speaking to me. Just yesterday, I went out shopping, and one man saw me and came to me and said, oh, madam, I saw you the other day in the church. I was like, oh, yes. So that's the kind of relationship you want to build. So by the time you come in with your different researches, because you can always go back and use that community, they will then go out into their community and bring other people who might not be members of their churches, who might not be members of their community, but they share the same characteristic. Once you're done with your research, keep going back, because that's the way to build that relationship. If you don't do that, they will look at you and say, oh, it's only when you want something, that's when you come. And once you're done, you're out, you're out. We don't want that kind of person. So you need to keep building it and keep bringing services, keep, alerting them to new things coming up and how it will benefit them. And that is the way to go about it.
Thank you so much, Hilaria. 100%. Charles, I think I'm right in saying you've been involved in research as both a carer and a patient. So how has your experience differed when engaging with those 2 different hats on?
Okay, well, I think it's myself being an elderly patient, multimorbidity, I recognize many of the issues there. And I think I can bring my own personal experiences there. When I look at being a carer, the difficulty I have, or I had, is that I was a carer for my late mum, and I was very much subjective there. What I've learned is to put the cases in these research studies of carers who are not like myself, carers where English might not be will not be necessarily their first language. And one has to actually, when one is involving those carers, to give them more time and to try and teach try and explain to the researchers that when they're interviewing them, they must give them more time to understand what the questions are being asked. And sometimes if they have the person they're caring for with them, give them time to talk to the patient and get responses there. And I think that I've learned in the last few years that we have to pay more attention to, as Hilaria was saying, to those people who are not like ourselves. I echo what Hilaria was saying, and if I can just say on that, that in research in London, in some of these studies, there are many people like myself, elderly, retired, white, British, and the difficulty is, as Hilaria was saying, is trying to get more people from the other communities in. And I very much welcome the work that she is doing there. And we, in our own way, we try and do this in each of the research studies that we get involved in. And if I can just go back, Gary, to the point is that how to get the researchers. I've been involved in maybe 12 studies so far. And the researchers move from one research study, they complete that, and then they go into the next one. And if they have built up a relationship with a church, a community, they can go back to that group as well, again, for the next research study that they might be doing.
Fantastic. Thank you very much, Charles. Both you and Hilaria, in many ways, have answered my next question, but I'm going to ask this question of Milka. But if Hilaria and Charles want to jump in and add to it, then please do. Now, we want research, don't we, to be relevant to everybody. So it's important that people with a range of different characteristics and from different communities help and get involved in our research. So how, Milka, easy question for you, how do we create an environment where everybody feels that they can be part of a research project?
Well, for research to be relevant, you need different characters. It's just the same as a movie. You cannot have the same actor acting the whole movie. It's going to be boring, and I think it's just going to be like really empty. So you need to bring in like different cultures, bring in different members to the research. You have to create an environment where the differences are going to be celebrated. You cannot have people like with the same thoughts, with the same acts. People are going to learn. And then you have to create a space for culture shifts, create an environment with a culture of trusting. There has to be trust, there has to be care, there has to be empathy in it. And you have to form a better channel within the research, between the researchers and the community and the stakeholders, that especially that relationship between the researchers and the community has got to be there. And it really, really has to be a good relationship. Otherwise, it's not going to work. The people the community are not going to trust the researchers. And when they're not trusting the researchers, then they'll not be able to open up. One other thing is they create an environment where everybody can speak, because it doesn't matter who is speaking, what they're saying. You might think that this is not important, but when you sit down and look at it, you're going to later on learn that whatever it is that each and every person says is important. You just have to know where to put it in. So some cannot be public speakers. Others are just good at writing. You also have to create those kind of channels that if there are those that are able to just speak, let them speak. If there are those that are able to just write, let them write. So that openness is really, really important.
So finding a way to enable people to express themselves on their terms.
Yes.
Because I think that's so right, because say not everybody is a great speaker or doesn't want to speak, and they may express themselves, be it poetry, song, or what. I'm not about to burst into song. I just want to tell you that now. But they express themselves in very, very different ways, don't they? Thank you, Milka. Hilaria, have you got anything to add to that?
Can you just repeat the question for me, please?
Yeah, it's that idea. How do we create an environment so that everybody can be involved in research? So we're much more inclusive in our research practices.
Yes, so it's reaching out to different communities. I am actually based in Salford, and it's just like being at home. There are different people from different countries. However, they are not represented in research. And just yesterday, I was at an event speaking, and they were talking, and in the room there were more people from the white community than from ethnic. We're actually only 3 Black people, 1 Asian person in that room. And I stood up to talk, and I told them, I said, we're all talking about research and how we can do a lot. Have you reached out to the Hong Kongers who have just moved into Salford? Have you reached out to the Portuguese-speaking community, all the Spanish-speaking communities? You haven't done that. And I said, listen, I'm not criticizing. I'm just saying that if we want to do something and we want people to be involved in the projects we're doing, we need to reach out to them. And if you do want to reach out to them, I'm already in touch with those communities. I can take you and introduce you to them. It will be slow because it took me quite a while. So what researchers should be doing is research the number of the different communities or the different people representing different countries in their community. Because if you're only building research or solutions to a particular community, it doesn't help across board. And that's what we found with the English system. They built their system around their citizens. And then as time went on, people came in from other countries, Africa, Asia, you name it, America. They're all represented here. South America, they're all represented here. How do we get them involved in research so that whatever solutions we are building up to help with whatever disease or whichever area we're researching into, those people's voices and what affects them is represented, their voices are represented, so we can apply those solutions to each community, because one size doesn't fit all. And believe me, a lot of researchers are taking that on board, but it is really hard to get into those communities because there's that distrust from people coming from outside. So how do we get in? Try as much as possible to find one person, just one person can get you in, because they will take you to their leader, and then go in a very humble manner and talk to them about what you want to do. And once you finish, don't just walk away. Go back time and again to say, I'm just checking to see if there's anything that's happening, if there's anything that you people want us to do, that we can work together. Find the scholars, find those, the ordinary people who would come and tell you, especially men who would not willingly go to a doctor to tell them about the issues that are wrong with them.
Sure.
Find someone to get you into that community and get them involved. That's the best way to go.
Thank you, Hilaria. I am now going to turn, thank you to all the panelists. I'm now going to turn to the questions that have been asked by one of our audience. Samu, have you got any questions, or do you want me to run through the Q&A?
We do have a lot of questions. Perhaps in the interest of time, you might want to take maybe 1 or 2 questions. There's one here that has perhaps the top voice, comes from Anonymous. Says, nice to meet you all. My question is, how do you overcome the challenge of a vulnerable community that other researchers have reached out to, but did nothing to them after research?
Can I come in on that? Okay, so I think that, as I said before, a lot of people are vulnerable. I'm vulnerable. And usually researchers, if they're looking for a particular area, like, for instance, kidney research, they use somebody like me who is not afraid to speak out. Now, in terms of those people who are vulnerable and they are abandoned afterwards, is a no-no. Researchers should try and go back and build that relationship, explain the reason why they've not seen them in a while. Because sometimes you get engrossed in research and you're finding the solutions, you get excited. I've just finished my public health research recently. And, I didn't go back immediately to the community, but I went back to show them my certificate, to say I've finished the research, but now this is the time for us to implement my research. So we are working on that. And that is what researchers should do. Go back, talk to them. Yes, you've abandoned them. they feel abandoned. Maybe you haven't done that. So this is a time for you to go back and say, listen, the reason why I haven't come back is because I have been so engrossed in this, because I'm finding a solution for us. But in the meantime, instead of, when you go into a community and leaving almost immediately, think about getting a contact person, maybe the local chief community head, or a local influencer, or the church. Try and see if you can build a relationship with them and keep in touch with them. There's so many ways you can do that now. Go back to the basics. WhatsApp, text, call. If you can't call, text, just to say, I'm here, I've not abandoned people. It's just that this is what's happening. They can then feed back to the community. So it's just making them understand that it's not as if you've abandoned them, it's just work, really. And you'll be surprised how people would understand, rather than just keeping back and saying, oh, I don't know how to go back.
Thank you so much, Hilaria. And you may want to go to the Q&A. There's a related question from Michael, who is saying, I agree about continuous engagement with the community beyond a project so that they do not feel that they are being used. However, funding cycles, or certainly all funding, is not always certain. How do you continue to engage with the community after the project once funding has ended? So if you can respond to that via the chat. I want to quite quickly pick another question, interestingly, from Michael, but this is for Milka. And he says, you mentioned that your research is spread across 8 countries. Do you have counterparts in those countries who know the local communities closely? How do you coordinate CEI across those settings?
All right, yeah, so we've got countries where the research is taking place. I am just the lead, but in each of those countries where the research is taking place, there are also CEIs, there are lead CEIs. I look after the whole CEI, lead the whole project, but then in each and every country, there is a CEI that is also mentoring the other community engagement involvement in that country. Yeah, so we have them.
Thank you so much. I'm trying to look for a question here for Charles. There was a question as well from Adebajo that had quite a few votes, but it was on trust, and I feel that delegates have responded quite significantly on trust, so they can also respond to it via the chat, the Q&A answer live question. This one is from Anonymous, and it's for Charles. Would you say there was a good range of carers and service users being used in research overall? How are you finding payment arrangements being explained and delivered to you? I think you're on mute, Charles.
There we go. Sorry about that. In my experience, the answer is probably no, there are not sufficient carers or carer involvements from different communities in the research projects that I've been involved in. We do our best to recruit them, and I think the important thing is to, as we've heard before, is feedback. We find that carers, if they feel that they've been listened to in a particular research project that they've been involved in, they will support again and tell their fellow carers in their carer groups. The other thing is that we find that with researchers, they want to get some people to interview for their research. They want to get sufficient people to interview. And what we also look at doing is that if we give them feedback and if we give them payment, in the UK, we're able to do that. We give them payment and travel expenses to come in if they're taking part in something centrally. We find that the researchers we find that the people who participated in answering the researchers' questions, sometimes they come and join us in the research panels in the future. So that's been a success as well. But the great answer is we probably do not have sufficient carers amongst our group.
Thank you so much, Charles. So Gary, there's so many questions here and all very interesting, but I think in the interest of time, we will not be able to go through more than what we have. Can I advise our panelists, please, to just go through those questions and respond to them so that our delegates can hear your thoughts on those. Gary, I wondered whether you had anything else to say. Otherwise, I want to invite.
No, I'm fine. Just want to thank our wonderful panelists. I really enjoyed that. Thank you so much.
Thank you so much, Gary. So now it's my pleasure to invite the NIHR Director for Research Inclusion to introduce herself and then offer her reflections as well for the webinar today.
Thank you, Salmo, and thank you, Gary, for a great event. I wanted to kick off, well, I'll start with an introduction. So my name is Esther Makuka, and I am the NIHR Director for Research Inclusion. And depending on the day, that could mean a variety of things in terms of my responsibility. But part of my responsibility is to work closely with our PPI managers and leaders across the system, people like Samuel, people like Gary, to ensure that we are thoroughly thinking about inclusion and diversity within our approaches to CEI and PPIE, but also to learn what's working well and to take those learnings and improve our processes. So it's been fantastic to be part of the conversation today and to listen to Hilaria, Charles, and Milka. What a fantastic display of not just diversity of representation, but also diversity of experience and diversity of expertise. So thank you very much to our panel members for all of your input today. I thought the key takeaway messages for me today is that we need diversity. We need diversity in our approaches. We need diversity in the NIHR PPIE community. We need diversity to shape the work that the NIHR does and the way that we engage with communities. Additionally, we can't just bring the diversity in and leave it there. Charles mentioned that he had to be supported by the researchers to understand what his role was, and it's important that as the NIHR, I think for me, in terms of my leadership in the NIHR, is that we're thinking carefully about how we support our public and patient contributors to effectively contribute to the NIHR system. It's not just about bringing people to the table. It's also ensuring, as Gary said, not just tokenistic inclusion, but meaningful engagement, meaningful inclusion. That means, as Milka said, we're not forcing people who don't want to talk to talk. We need to also have diversity of opportunities as well. And that means that we can bring a range of people who have different learning preferences, people from the neurodiverse community, people from ethnic minority communities to effectively contribute. And I think for me, this is just a restatement of the work that needs to continuously happen within the NIHR to ensure that we are an inclusive organization, that we're an inclusive funder, and not just inclusive in terms of money that we give out, but inclusive in our systems, processes, and within our culture as well. And then additionally, because I'm mindful of time, I think the key thing I was hearing around ensuring we build trust with communities is that we need to get in touch with the right people to represent communities effectively. I was almost laughed when I recognized what Hilaria was saying about changing her tone when she was talking with her community. I can tell you I don't sound like this when I'm talking to my husband at home.
Exactly.
It's a completely different Esther. And I think this is what diversity of experience, diversity of thought brings in, is that we know that there are different ways. Your intonation has to be different because intonation means that people translate things differently. And then finally is that we need as the NIHR to keep investing in training and support. Yeah, Milka, you mentioned being an event manager and transitioning into learning what SBD means. I wouldn't even know that. And I know coming into the NIHR from a different sector meant that I had to learn a whole different way of doing and being and language, and lay members need to be empowered with the training, capacity building that we need. We are committed in the NIHR to diversify our talent pipeline, to invest and diversify our talent pipeline. And that's one arm of the NIHR research inclusion strategy. And I think one thing I would like to leave everybody with today is that because of that commitment, we will continue working with people like Salmo and Gary and Hilaria, Charles, Milka, to ensure that we have a thorough and robust inclusive process around PPIE and CEI. So thank you very much for today. I thoroughly enjoyed the session, and I look forward to being part of future sessions as well. I'll hand over to Salmo.
Thank you so much, Esther. And yeah, thank you so much for all our delegates. The webinar recording will be available on our social media channels. If you registered, well, the link that you used to register, you will be notified once that the webinar recording is ready and available. And please share it as widely as you can. But thank you everyone for joining us today. And thank you specifically to our panelists as well. And we hope that everyone, you have all taken something here for you out of this session today, and it has inspired you to enhance your approach to working with people and communities. And we look forward to seeing you again in the next iteration of this series. Thank you.